So we'll start with the 2019, the rest of the MCQs. Right? So you can see the screen. So we'll start. So yesterday last time we discussed mainly about this identification of what do you call this? Of a SLE flare-up from a actual infection in a SLE patient, right? Because SLE patients and if the immunity in SLE patients is very low, so they can commonly get infections, right? So the main way that we identified that the patient differentiation is by checking for lupus manifestations. Lupus manifestations can you check whether the patient gets skin lesions, and then you also check whether the patient gets renal manifestations, right? These are the two most commonest lesions in SLE, right? And also in an infection, usually these will be focal symptoms. If the patient usually has a normal infection, however, there can be disseminated infection also. And in a SLE flare-up, usually ESR levels will be increasing with normal CRP levels, right? However, in an infection, ESR levels will increase and also CRP levels will also increase. The exception to this rule is that in SLE patients with serositis, in the sense that when the pericardium or pleural cavity is involved, that can actually cause increased ESR and CRP both. Okay, that is one feature. And then the next feature that is useful for differentiation from SLE and infection is the anti-double strand DNA titers, where the theta level will actually increase in a flare-up and the anti-double strand DNA theta level will stay normal in a simple infection, right? That is also one way that is useful to differentiate a SLE flare-up from an infection. And then you can also do a full blood count and check whether there is neutrophilia, and then you can also check whether there is lymphocytosis, right, in an infection. However, these things are sometimes doubtful in patients with lymphopenia, right? In leukopenia, SLE can commonly cause leukopenia with infections, so they of course this will be low. And then you can also do a blood culture in an infection, which will be positive, right? However, the blood culture will be negative in a SLE flare. Okay, so you need to understand these things. It will be negative in SLE flare. Okay, so these things are very important things to understand. Specifically, you need to know what the investigations are used in diagnosing SLE flare-up. The investigations that are mainly used to diagnose SLE flare-up are anti-double strand DNA titers, right? That is one thing that is used to diagnose SLE flare-up. And then C3 and C4 levels is also another thing that is used to diagnose an SLE flare-up. And then another thing that is used for diagnosing SLE flare-up is ESR and CRP. So this is however non-specific, right? Mainly these are the ones that are useful in diagnosing SLE flare-up and infection, the investigations. And the treatment is, as you know, very straightforward. So for infection, you need to give the patient IV antibiotics, and you need to do focal control of the infection if there is abscess or a collection. However, in a flare-up, you simply need to pulse the patient, usually with IV methylprednisolone, or usually you start the patient in a high-dose oral corticosteroid dose. Okay, so these are the two major ways that you differentiate SLE flare-up from an infection, because clinically both of these things will present in a very similar manner, right? So clinically, sometimes differentiating an SLE flare-up from an infection is non-specific, right? Specificity is really low. Okay. So, Ale, etika therunada? Deshabandhu?
Oh,
Yes.
So now we go to the 42nd one. A 43-year-old patient from Middle East presents with cough and progressive shortness of breath for 4 weeks with malaise, loss of appetite and 10 kilogram weight loss over 6 months. So that is a significant weight loss. Okay. So he has a history of recurrent infections over the past year. On examination, there is bilateral lung crepitations. On investigation, there is neutrophil leukocytosis. What is this 2.9? Is it reduced or increased? Neutrophil levels. Reduced. And bilateral hazy infiltrations, right? Bilateral hazy infiltrations, interstitial opacifications in the hyla area. Okay. So now
AC කියනකොට
AC කියන්නේ radio opaque කියන එක. ඒ කියන්නේ the radio lucent කියන්නේ කළු පාරට පේනවා කියන එකනේ X-ray එකේ. Radio opaque hazy කියන්නේ සුදු පාරට පේනවා.
හරි.
So you guys already know the diagnosis here. What do you think is the diagnosis here in this patient? For 4 weeks. So this looks like a chronic pneumonia, no?
The D?
Huh?
Is it pneumocystis?
Excellent. Why?
Hyder area.
Yeah.
But what do you think is the condition he is having? Yeah, this is likely AIDS, right? AIDS due to HIV infection. What are the clues in the history that point towards AIDS? Good. That shows that zero conversion of the infection, and then recurrent infections have taken place. So AIDS is already there. So something I think now. What are the other features of pneumocystis jirovecii pneumonia? මම ඊයේ පාර කියලා දුන්නා මේක ඒ විදිහටම ආලා තිබ්බා. In pneumocystis jirovecii pneumonia, what is the treatment? Hello. Treatment. What antibiotic?
Okay,
what antibiotic? Apa antibiotic කියලා මොකද? What antibiotic? It is usually cotrimoxazole. හරිද? It's usually cotrimoxazole. So some patients who have got this infection are on cotrimoxazole prophylaxis also. Okay. So what are the other features of pneumocystis jirovecii pneumonia? What sort of pneumonia does pneumocystis jirovecii cause? Good. Bronchopneumonia. And then what else is there? There is usually fine end inspiratory crepitations. Okay. Fine end inspiratory crepitations are there. And then what else are there? What else is there? The next thing is in pneumocystis jirovecii pneumonia, usually the patient's saturation will drop. Right? On exertion. Exertion karate, their saturation will be like 86%. And then the fourth feature of pneumocystis jirovecii pneumonia is these patients will have bilateral hyla infiltration. Okay. මේවා ටික අපි දැනගන්න මොකද pneumocystis jirovecii දිගටම ආපු හින්දා they will ask sometimes something different this time. Okay. And I will also teach you a bit about AIDS because that also can be asked. In Sri Lanka, what are the high risk age groups for AIDS? HIV infection. What are the high risk groups? Hello.
B.
Right, homosexuals. Anything?
Beach boys lah, may
Beach boys.
industry.
What else?
Industrial sex workers lah.
CSWs.
May
What else? MSM. What is it? Yeah, homosexuals. Any others? IV drug abuses. Right. So, what are the phases of AIDS? Phases of HIV infection. Actually. Yes. So the first one is acute seroconversion stage. The second one is dormant stage, where the patient's immunity is still not reduced. However, the virus has now entered the lymphatic tissue and is now infecting all the WBC in the body, especially CD. Monolymphocytes may AIDS will infect කරන්නේ. CD what? Oh yes, CD4. ඒ cell එකේ නම මොකද්ද? T helper cells, no? Right, so and the final stage is AIDS stage, acquired immune deficiency stage. Now, what are the prevention methods that you can provide for a patient with AIDS?
barriers පාවිච්චි
Good. Now, prevention is what? Avoid sex. You can ask the patients to avoid sex if possible. B is you can ask the patient to use barrier contraception. Okay. And what is C? C is you can contain yourself to only one part. Right? These are the prevention modalities of AIDS. And then you can also do post-exposure prophylaxis. Okay. So, to which patients do we need to give pre-exposure prophylaxis? Is there something called pre-exposure prophylaxis? Yeah. To hide some high-risk patients, we can give pre-exposure prophylaxis. මේකේ මට තව එකක් අමතක වුණා කියන්න. Foreign workers, right? Foreign workers, especially workers going to the Middle East. Right? ඔය පහ තමයි high risk patients. Okay. Now there are certain things called AIDS defining illness. Right? HIV, AIDS defining illnesses. Tell me a few if you can remember. මේවා තියනවා නම් අපි one thing is that මේවා තියනවා නම් ගොඩක් වෙලාවට අපි AIDS තියනවාද කියලා ඒ patient එක check කරලා බලනවා. Anything else?
TB පුළුවන් නේ?
TB. Good. Especially like what? Candidiasis. Anything else? Cervical cancer is also AIDS defining infection. cervical cancer. And then Kaposi sarcoma. If diagnosed in a patient, you need to check for AIDS. So these are the AIDS defining illness. There are two groups of things, right? Make a AIDS defining illness to what? ඒක තියෙනවා වර්ග දෙකක්. එකක් AIDS highly suspected infections. AIDS highly suspected illness. අනිත් එක AIDS defining illness. ඔය වර්ග දෙකම you need to know, right? මොකද ඒවා සමහර වෙලාවට knowing these will be helpful. And then what is the how do you diagnose a patient with AIDS? AIDS. How do you diagnose a patient with AIDS? At which stage is it useful? In the acute seroconversion stage or? In the AIDS stage, what can you use? That is screening, ne?
Can't we use blood?
Huh?
Can't we use blood?
Yeah, we use blood. But what do we use? The blood, what is the test that we do? So this is dormant stage is also known as chronic HIV. So what is the goal of treatment in a patient with HIV? Now diagnosis is this. How do we treat? Treatment of what is antiretroviral therapy? What is the novel treatment modality for antiretroviral therapy? Art therapy. What is that? Nothing මතක නැහැ. ඒක heart කියන එකේ mnemonic එකක් තියෙනවා. Heart highly active antiretroviral therapy. Highly active antiretroviral therapy. And so we'll go. What is the goal of treatment now? Antiretroviral therapy heart එක හැමෝටම දීලා. Then how do we check the patient? What are we checking in the patient? Yeah, one thing is we can check for the viral load. Anything else? We can also check for the CD4 T cell count. Okay? So the goal is to maintain the CD4 T cell count above a certain threshold that will prevent AIDS. Right? And the heart therapy will have a lot of side effects. These patients have increased risk of heart disease, right? These patients have increased risk of cholesterol deposition. They have liver problems, right? So there are a lot of adverse effects. So managing these adverse effects and then maintaining a good CD4 T cell count are the main objectives of treatment. Okay, so universally now WHO has identified that HIV treatment should be provided to all patients free of charge. So that is what we do for HIV. Now mainly I'm trying to see what sort of diagnostic investigations can be used at each different stage. So baseline investigations of newly diagnosed HIV seropositive patient. These are for after diagnosis, no? Say AIDS defining illness. So these are the age defining conditions. So it doesn't mean that these patients have AIDS, but there is very highly likelihood that these patients with these infections, and not only infections, you can see that certain types of cancers are also here, right? And when these things are there, you need to suspect AIDS, right? So we'll see. Mm. What is the commonest type of HIV in Sri Lanka? There are two types, no? HIV 1, HIV 2. What is the HIV commonest HIV type in Sri Lanka?
2
One is Matagidir HIV 1. Let's see.
අර එක නරක එකක් තියෙනවනේ මොකද HIV 1 හරි 2 හරි මොකක් හරි.
Yeah. So HIV 1 එක තමයි ලංකාවේ තියෙන්නේ, HIV 2 තියෙන්නේ ඇෆ්‍රිකාවේ. Okay. So this is the HIV diagnostic algorithm. The first one we see is we check whether the antibody is there, and then antigen is also tested, right? And then so depending on the antibodies, right? Antibodies we can identify whether the patient is having HIV or not, right? Antibody test. ඊට පස්සේ ඒක බැරි වුණාට පස්සේ ඒක නෙගටිව් වුණොත් we do HIV PCR, DNA PCR. And then when we do HIV DNA PCR, we can diagnose whether the patient is having the actual HIV virus or not, right? So antigen and antibody test tama main HIV වලට තියෙන්නේ. So what is the confirmatory test for HIV? Confirmatory test for HIV. Confirmatory test is Western blot test. Western blot test. This is also similar to PCR, HIV DNA PCR. Okay. So antigen test and ELISA are similar. So what you check in the antigen test is also just screening. We'll check now. HIV කොයිගුණ පහන්නකුල HIV is common. So these are the HIV tests. Okay, so the HIV is that. Sometimes they might ask, that's why I included. So these are the HIV tests. ELISA is a screening test. Rapid tests are also screening. But Western blot is confirmatory. You can use the other ones like PCR also for confirmatory tests. PCR and Western blot are two different things. This is one. Remember, Western blot is confirmatory and PCR is also confirmatory. Other ones are just for screening. We'll go to the next one. 50-year-old diabetic patient presented with left lower limb cellulitis and was given IV flucloxacillin according to national guidelines. While on treatment on third day, he developed skin blistering, hyperpigmentation, erythema, and fever. a culture was sent, and after 48 hours the results came as methicillin sensitive staph aureus. What is the next step of management? So he's on IV flucloxacillin. So what is the next step of management? Yeah, this is the management. Why is that the management? Yeah, then we have to add another penicillin to this patient, penicillin or another antibiotic. Usually, what is the antibiotic that is given for these patients if this doesn't respond to flucloxacillin? Usually, what you add is clindamycin. If MRSA is diagnosed, what is the antibiotic that is usually started? Yeah, you can go with vancomycin. Is meropenem effective against MRSA? Sure. Yes.
Wait, Arunaja.
Yeah.
So we increase the dose, and if that also doesn't work, we add. That's so.
Yeah.
And that vancomycin, from where it came?
What
What about vancomycin? Why did you add?
Yeah, vancomycin no need to add unnecessarily, because first we try with one antibiotic and then we can combine the antibiotics if you are suspecting anaerobe, or usually clindamycin is given if you are suspecting gram negative infection or if you are suspecting anaerobic infection. Okay, so when these two also doesn't work, only we have to now think of change in the antibiotic. And usually the culprit organisms for this cellulitis are usually group A beta hemolytic streptococci, MRSA or MSSA, right? Usually flucloxa will work for MSSA and group B strep. However, MRSA will not respond to flucloxa. So first we give flucloxa to the maximum threshold, and then we can combine to cover these two organisms as well in case there are these organisms involved. And then even if that doesn't work and the patient is still developing complications, then we again repeat the cultures, we again repeat the tissue or pus fluid cultures, and then perhaps we go for MRS. If MRSA is diagnosed, we can go for vancomycin.
Okay.
Usually, the first recommendation in treating cellulitis is IV flucloxacillin. What is the other antibiotic that can be given if flucloxa is not available? Yeah, coamoxiclav.
To treat what?
If flucloxa is not available, we can give coamoxiclav also. Okay. If flucloxa and coamox, what is the most generic recommended antibiotic? Penicillin. C penicillin. How much? 8 million units.
Million?
Yeah. 8 million units TDS, if I can remember. Oh, මං හිතන්නේ penicillin දෙන්නේ නැත්නම් MSSA penicillin වලට ආන්සර් කරන්නේ නැති හින්දා. group A beta hemolytic strep නම් ආන්සර් කරනවා. group B වලට group A beta hemolytic වලට තමයි බං universally penicillin වලට sensitive. නෑ group A විතරයි තියෙන cellulitis වල. Usually group B එන්නේ නැහැ cellulitis වල. Right? So now usually when you give antibiotics, remember this rule. First start with one antibiotic. Right?
Okay.
And then the second one is increase the antibiotic dose to the maximum threshold. And then you can switch to another antibiotic. And the fourth one is sometimes if after switching also not working, you can then only combine. However, if you are suspecting some gram-negative or anaerobic organism, especially in a diabetic patient with cellulitis, and if they are having things like wet gangrene and so on, it's better to give anaerobic covering antibiotic as well. So usually what is given is clindamycin. We first try with the combination here, and then we can switch. So there is a small exception in this condition. Okay.
Okay.
So again, what are the antibiotics that are effective for MRSA? Commonly asked.
Vancomycin?
Uh, uh, Anything else? Vancomycin, teicoplanin. Then you can also give linezolid, and you can also give daptomycin. Daptomycin again, daptomycin. However, don't give daptomycin for pneumonia, MRSA pneumonia, because daptomycin is inactivated at the alveolar epithelial surface, so this won't be effective. Okay. What are the antibiotics that are effective for methicillin sensitive Staphylococcus aureus? Yeah, usually penicillin antibiotics all are useful, except the normal penicillins. You can give things like coamoxiclav, and then you can also give flucloxacin. The aminopenicillin group you can use, right? Flucloxacillin. Penicillins usually not used because these are staph, so not strep, kind of a more virulent organism. So usually penicillin is not given. However, the commonest organism considering is group A beta hemolytic streptococci. Usually penicillin is the recommendation, but it is commonly not given because MSSA is suspected, and usually flucloxa covers both MMSA and group A beta hemolytic strep. ඒ දෙකම කවගෙන ඉඳ මුලින්ම දෙකම නැති වෙලා යන flucloxa තමයි practice එක දෙන්නේ. But according to international recommendation, penicillin is the best antibiotic, first antibiotic. Okay, understood?
Okay.
Oh, ඒක aminopenicillin එක.
Okay.
So
But we can't use penicillin like you said we can't use penicillin.
we can use, but usually not used.
Okay.
I'll include these photos in the comment answer scheme so you guys can learn. I mean, you can use this as a antibiotic maker, like a small thing. And find out what are the antibiotics that are usually given. Usually it's these. And then also learn about the antibiotics that are commonly given for pseudomonas. What are the antibiotics that work for pseudomonas? Usually the antibiotics are meropenem, gentamicin, Pseudomonas. You can also give piperacillin tazobactam. Piperacillin tazobactam valdi, ticagrelin. And then for combination එක ඒ කියන්නේ tazobactam කියන්නේ අර coamoxiclav වගේ enzyme එකක් inhibit කරන එක. Right? හැබැයි ඒකේ penicillin කියන්නේ තමයි piperacillin කියන්නේ. ඊට පස්සේ තව එකක් තියෙනවා මම remember right cotrimoxazole වලට treat කරන්න පුළුවන් pseudomonas. පොඩ්ඩක් ඉන්න check කරන්න. There is a mnemonic for this. This might also be asked for, right? Pseudomonal antibiotics. This is one. Mafia pseudomonas. Meropenem, citronam, fluoroquinolones, imipenem, gentamicin, tazobactam, and then not cotrimoxazole. Fourth generation cephalosporins are also effective for pseudomonas. Fourth generation cephalosporins. And there is also you need to know about the antibiotics that can be given for anaerobic organisms. Anaerobic organisms. What are the antibiotics commonly given for anaerobics? Metronidazole. Anything else? Then the pullo have not very effective. Anything else? Clindamycin. Anything else? Fluoroquinolones වැඩ කරනවා. මොකද? Cipro, levofloxacin ඒ වගේ. Right? ඒ ටික තමයි දෙන්නේ. Okay. So next, a 35-year-old male previously diagnosed with depression, found confused at home, bored to casually by his wife. There is increased alcohol consumption for the past 3 weeks. He is conscious but confused. He has pinpoint pupils and normal deep tender reflexes in both upper and lower limbs. Blood pressure is 100/60, low. Pulse rate is 60. Labored breathing. What is the most likely underlying cause?
Methanol.
Underlying cause.
Huh? Methanol poisoning.
Why do you say so?
He has been consuming alcohol for past 3 weeks, and he had like features of those things. Methanol poisoning.
What does organophosphate do?
But there doesn't say about him.
Yeah. So what does it increase?
Heart rate.
And then bradycardia is also there, no? And then why do you get labored breathing? Because of anything else? No, because of bronchoria. Because their secretions also increased.
What does labored breathing mean?
Labored breathing?
Yeah.
It's actually difficult to breathe.
Okay.
Blood pressure is 100/60. Is this low? Do they get low blood pressure in organophosphate poisoning? Yeah, they can usually get. And also, is conscious but confused. Is conscious and confused. Usually in a pontine hemorrhage, Will he be conscious?
No.
No.
Don't.
In Wernicke's encephalopathy, will he be conscious?
No.
He can be conscious, but he'll be confused. Right? In methadone poisoning, usually they can be conscious or unconscious both. Antidepressant overdose when නැත්තේ I mean. It can be a mixture of anticholinergic and adrenergic. Right? In adrenergic mixture එකක් තමයි එන්නේ. What is the commonest antidepressant that can be toxic in overdose?
Tricycle.
There you will get ventricular tachycardia, so you won't get bradycardia. This is also wrong. So out of the ones that are given, what do you think is the likely diagnosis?
Organo?
So how can this alcoholic patient get organophosphate poisoning?
Yeah. Did she drink some organophosphate?
Yeah. Usually they can get because they are not very oriented. These patients can actually go drink organophosphate thinking it is alcohol. That can be one reason. And also because these patients are deeply depressed, he might have had suicidal ideations also. So he might have drunken that as well. So
okay, Wernicke ඉන්නේ බැරි ඒව.
So Wernicke වෙන්න පුළුවන්. හැබැයි Wernicke වෙනවා නම් අපිට අනිත් clues තියෙන්න ඕනේ. කියන්නේ what are the three features of Wernicke's encephalopathy? තුනක් තියෙනවනේ. ඒ තුන තියෙනවද කියලා මෙයා දීලා තියෙන්න ඕනේ. ඒවා තුන තියෙනවා නම් Wernicke වෙන්න පුළුවන්. What are the three features of Wernicke's encephalopathy? They get confusion. That is one feature. Or they will be drowsy. Okay? And then they will have ataxic gait. And they will also be having nystagmus. And these are the features of Wernicke's. ඒ තුන දීලා නැහැනේ. ඒක හින්දා මට හිතෙන්නේ හොඳම වැඩේ දීලා තියෙන උත්තර වලින් organophosphate වලට යන්නේ. Okay.
සාමාන්‍ය අර organophosphate දෙද්දි කියනවා නේද මේ ෆාමා කෙනෙක් කරේ නැත්තම් ඔය මේ මොකක් හරි එහෙම කතාවක් කියනවා නේද?
මේකක් කියනවා. right දැන් මේ පේපර් එකේ පොඩ්ඩක් ඒ වගේ ප්‍රශ්න තිබ්බා. මේක උඩින් ඔයාලට මතකද? ෆීමේල් කෙනෙක් ඇවිල්ලා තිබ්බා ඇල්කොහොල් පාවිච්චි කරලා හැබැයි යා මේ ප්‍රශ්නේ ඇල්කොහොල් වලට අදාළ කන්ඩිෂන් එක නෙමෙයිනේ මෙතන අන්තිම උත්තරේට ආවේ. මෙතන අන්තිම උත්තරේට ආවේ මතක විදිහට ලිම්ෆෝමා හින්දා ආපු හිමලේ.
Oh.
Right? So like that, we have to see the complete picture. මොකද? ඔව් ලනු දීලා තියෙන සමහර වෙලාවට පයසම වෙනවා.
What?
No, sometimes the details try to mislead you. You have to be careful. That's all. Okay. 45. Take a share the Deshibandu.
ඔව්
What
ඒ
are
ඔරිජිනල් පේපරේ තිබෙන්නේ නැහැ නේද ඒවා?
මොකද්ද?
ඔරිජිනල් අපේ පේපරේ තිබෙන්නේ නැහැ නේද එහෙම මොකක්වත්?
නෑ මේ ලනු දීලා තිබ්බ. ඇත්තටම තිබ්බ මේක. Right? What are the causes of pinpoint pupils? Hello. What are the causes of pinpoint pupils? Bonus will be pinpoint in that. Meiosis වල. මේ ටික දැනගන්න ඕනේ because the toxicology වල ප්‍රශ්නයක් එනවනේ. එතකොට ඒකට answer කරන්න ලේසි. Pinpoint pupils මොන conditions වලද?
Okay.
Usually in opioid overdose. In Sri Lanka very uncommon because IV opioids නැහැනේ ඒකින්ද. Patients වල IV opioids අපි දෙන්නේ නැහැනේ ඒකින්ද usually less common. What else? Pontine hemorrhage can also cause pinpoint pupils. Okay. What else can cause pinpoint pupils? Organophosphate poison. Right? ඒත් එක්කම තියෙනවා පොඩි දෙයක් මම කියන්නම් ඒකත් ඔයාලට මෙතනදම කියලා දාන්නම්. දැන් toxicology I have taught you guys know how to manage a toxicology patient briefly. SAS RSI කියලා මතකනේ මම කිව්වා මේ resuscitate කරන මුලින්ම. ඊට පස්සේ R කියන්නේ මුලින්ම resuscitate ඊට පස්සේ RSI කියලා ඒක mnemonic එකේ. ඒකට ඒකේ පළවෙනියටම අපි patient එක stabilize කරාට පස්සේ toxic එක injection කරාට toxin එක මොකද්ද? ඒක inject කරේ කොච්චර ප්‍රමාණයෙන්ද කොච්චර කාලයකට ඉස්සෙල්ලාද කියලා දැනගන්න ඕනේ. Afterwards, if it is less than 4 hours, gastric lavage. If it is less than 4 hours, we can give activated charcoal also, right? However, later on, we will have to go for systematic supportive treatment, either with hemodialysis or with antidote treatment, right? So that is basically the treatment modalities we discussed. And we have to continuously monitor the patient's vitals. We have to continuously do investigations to check whether the poison patient's organs are being affected by the poison. So renal functions, liver functions, those things need, and blood gas to check acidosis, those things need to be done in monitoring. So when a poisoning patient comes, right? When a poisoning patient comes, there are toxidromes, right? Poisoning patient comes, there are toxidromes. Toxidromes කියන්නේ ඒ toxin එක ingest කරාට පස්සේ there are combination of clinical manifestations that are seen in a patient, right? Combination of clinical manifestations usually seen in a patient. So what are the toxidromes that you guys know of? Jarna?
Yeah.
What are the toxidromes that you know?
Toxicrome meaning?
Toxidrome means collection of clinical signs that comes about when a patient ingests a certain type of toxin. There is a opioid toxidrome. You can opioid overdose එක patient එන clinical features combination එකක් තියෙනවා. ඒකට කියනවා opioid toxidrome. And then there is also something called cholinergic toxidrome. Cholinergic toxidrome is what you see in organophosphate poison. And then there is also a toxidrome condition called adrenergic toxidrome. What is the adrenergic drugs? Overdose not possible patient adrenergic toxidrome, right? So these are the common toxidromes. ඒව දැනගන්න ඕනේ. මොකද අර SBA වල දෙද්දි ඔය features තමයි දෙන්නේ, right? Common toxidromes. And manifestations, right? So these are the common toxidromes: opioid, cholinergic, sympathomimetic and adrenergic, anticholinergic toxidrome. ඔය ටික තමයි තියෙන්නේ, right? Okay. So just know this because they will commonly give these and then ask you what is the drug or what is the type of poison or whatever, right? So opioid toxidrome, what are the drugs that cause opioid toxidrome? Huh? Yeah, IV morphine. In Sri Lanka, what is the commonest drug? Oral tramadol. Yeah. Pethidine gamuda එන්නේ අපිට. ඒක weak opioid. Cholinergic toxidrome, what is the commonest type of drug? Organophosphate. And paraffin නෙමෙයි. ඒකට කිව්වා තව නමක් තියෙනවා. Yeah, organophosphate poison තමයි mainly. Anticholinergic toxidrome එක මොනවා වගේද? TCA poison. Patient will get a combination of symptoms. Sympathomimetic toxidrome. Sedative and hypnotic toxidrome කියන එක එච්චර ගණන් ගන්න එපා. ඒක එච්චර වැදගත් නැහැ. Hallucinogenic toxidrome එක නම් ඉන්න පුළුවන්. Right? Usually hallucinogenic toxidrome එක ඉන්නේ මොන වගේ conditions වලද? Ice. What else? LSD වලින් overdose වෙන්න ලංකාවේ. මොකද දිවයිනේ ගහන්නේ පොඩි පෙත්ත 5000ක් විතර කෑමක් තියෙන මෙයාවේ. what else? මේ features ම තියෙනවා මෙන්න මේ වලට commonly in Sri Lanka alcohol overdose. ඒ කට්ටියට මේ features commonly වෙනවා. And then also this with alcohol withdrawal. Right? These patients also have hallucinogenic or toxicrosis. You have heard no delirium tremens, and then also wernicke's encephalopathy can commonly get what you call make hallucinogenic toxicrosis. Right? What are the commonest sympathomimetic toxicrosis? What is the drug that commonly leads to sympathomimetic toxicrosis? Amphetamines, methamphetamine, painkiller. These commonly leads to sympathomimetic toxicrosis. Right? But what is the use of amphetamines? Good. Methamphetamine ice වලට ඉන්නේ sympathomimetic toxicrosis. Right? And then ice වලට මේකත් එනවා. ඒකට hallucinogenic toxicrosis එකක් එනවා. And then අනිත් ඒවාට දෙනවා ඒවා හැබැයි ගොඩක් commonly use කරන drugs නෙමෙයි. And then cocaine can also cause sympathomimetic toxicrosis. Right? Is cocaine a stimulant or suppressant?
Stimulant.
It's a stimulant. Okay. Shape neither. These are the drugs, and these are the common toxicrosis that are seen in patients. Right? So remember that. Okay. So we go to the next one. A group of middle-aged 4 farmers, after a party at their Haina, admitted with to the hospital with nausea, vomiting, and abdominal pain. Everyone was drowsy or confused. Worst affected individual had new onset visual loss and bilateral dilated pupils not reacting to light. What is the most likely cause?
Methanol.
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 Cannabis overdose වෙන්න පුළුවන්ද? Not very common. Cannabis overdose is not very common. Food poisoning, can it happen due to food poisoning?
Not this much, right? Not like
usually
this.
food poisoning people get a simple diarrhea. What is the most dangerous type of food poisoning in the world? Botulism. In this, because of the botulism toxin, the patient will get what? They will get neuromuscular paralysis. So they will present with things like ptosis, respiratory distress, okay, and those features. Carbon monoxide poisoning, how will they present? Carbon monoxide poisoning කොහොමද වෙන්නේ usually? Any other ways? After burning, exposure to a burn or a fire, after inhalation of fumes, they can get carbon monoxide poisoning. These patients will usually have hypoxia and disorientation. Right? Methamphetamine overdose, what will that cause? That can also cause this kind of manifestations, but here the most important one is visual loss. Methamphetamine will not cause visual loss. Why does methanol poisoning cause visual loss? මම ඒකත් එදා කියලා දුන්නා. Formic acid. That is highly neurotoxic. That is why they develop visual loss due to optic nerve damage. Okay, so this is the methanol poisoning. Next one, 32-year-old man presented 2 hours after a cobra bite with severe pain and edema. Right? Okay, he developed blisters and necrosis up to knee. Is this an indication for Antivenom? No? CPA pain and
No, we do.
You know, we
For
do.
Cobra,
Why?
we give for local
Cobra
manifestations
may
also.
be
Yeah,
local.
only for Cobra,
Local
for local
manifestations.
manifestations we give.
Yeah.
I'll take that. Only in Cobra by. Cobra ke vitara local manifestations ulladino anithevalo always you need to have systemic manifestations. Understood? Oh. But no neurological signs or symptoms. WB whole blood clot index was normal. Blood pressure is 110/90. Pulse rate is 90. What is the most appropriate management? Guys?
G, IV polyvalent. G.
IV polyvalent antivenom infusion. Okay,
Mhm.
we go to the next one. 30-year-old businessman presents with generalized itching, non-itching erythematous maculopapular rash involving palms and soles. He also has generalized lymphadenopathy. Okay, he also has generalized lymphadenopathy. His liver enzymes are elevated. Right? What is the most useful investigation for diagnosis? So, what are the conditions which lead to palm and plantar rashes? What are the conditions infective conditions that commonly lead to palm and plantar rashes? One thing is hand, foot, mouth disease. Okay. And the second condition which commonly leads to palm and plantar rashes are what? Syphilis, right? Especially what sort of syphilis? Secondary syphilis. Okay. Oh, syphilis kena danagin. Right. මේක දැනගන්න තියෙන මෙච්චරයි. හොඳද? Syphilis is a sexually transmitted infection. What is the organism? Treponema pallidum. Right? Treponema pallidum. So, there are different manifestations of syphilis. When syphilis is usually sexually transmitted, and then there is also syphilis that presents as a congenital infection, but not very common. A congenital syphilis කියන එකත් එක manifestation එක. Congenital syphilis වල features තියෙනවා. Saber tibia කියලා එකක් තියෙනවා. මේ බබාලගේ කකුල් එහෙම ඇද වෙනවා. And then they also get this thing called Hutchinson's incisors. ඒ කියන්නේ කටේ තියෙන දත්වල කොන් උල් වෙනවා. හරිද? And then they will also have hepatosplenomegaly. And then they will have this maculopapular rash. හරිද? And then they will also have snuffles කියලා. ඒ කට්ටියගේ මේ හැම වෙලාවෙම හොටු ගලනවා. Right? These are the features of congenital syphilis. May be important for pediatrics. Okay. And then in adults, syphilis has three manifestations. One is primary syphilis. What is the commonest manifestation of primary syphilis? They can get a chancre. Chancre is commonly seen in penis or labia or mouth. Yeah, chancre is painless. Yeah, chancroid is painful. Right? And then this usually disappears after a few weeks on its own. And then comes secondary syphilis. Right? So, how do you identify chancre? Chancre is indurated. So, when you press the chancre, you can feel that there is this valavage. And then secondary syphilis is usually due to what these patients get is fever, and then they get lymphadenopathy, and then they also get what you call as condyloma lata. right? Very sticky, wet rashes. Rashes can body sticky, wet lesions in our genital area. And then another very important feature in these patients is they get snail track oral ulcers. They get oral ulcers that are like snail tracks. It can become very superficial oral ulcers in our patient. And they also get maculopapular rash, especially in the hands and feet, right? So hands and feet rash it is always in an adult secondary syphilis. In a child can be hand foot mouth disease. Okay. In hand foot mouth disease, what is the type of rash usually? It's vesicular. What is it? Hand foot mouth disease is a vesicular rash. Okay. In secondary syphilis, it is usually maculopapular rash. Okay.
Okay.
The tertiary syphilis is where you get gamma. Gamma means these patients get chronic large ulcers. They get chronic large ulcers in the head, face, nose. ඒ වගේ තැන්වල හරිම disfiguring ලොකු large ulcers වෙනවා. ඒ වලින් මුණ කැත වෙනවා. හරිද? And then they can also get gamma syphilis in the aorta and other connective tissues and blood vessels, right? So they can get aortic regurgitation. So many manifestations can take place in the connective tissues. And then in tertiary syphilis, there is also involvement of the nervous system. So sometimes patients with tertiary syphilis come with what do you call this neurosyphilis. How do neurosyphilis present? What are the two manifestations of neurosyphilis? So tertiary syphilis are types dekai, gamma and nervous neurosyphilis. What are the manifestations of neurosyphilis? They present with something called tabes dorsalis. ඒ කියන්නේ මම ෂෝට් කේස් කරද්දී කිව්වා dorsal syndrome, dorsal cord syndrome කියලා එකක් තියෙනවා. ඒ කියන්නේ posterior columns විතරක් posterior columns වල sensation එක යනවා. ඒක විතරයි යන්නේ. හරිද? ඒක එනවා neurosyphilis වලදී. ඊට පස්සේ තව එකක් එනවා dementia. මේකට කියනවා අපි මේ මතක විදිහට මොකක්ද නමක් තියෙනවා paralysis of the insane කියලා එකක්. Right, so dementia, right? So these are the manifestations of syphilis. So how do you diagnose a patient with syphilis? Yeah, so you can do screening test and then confirmatory test. What is the screening test? What is the confirmatory test? TPPA. Okay. Treponema pallidum particle agglutination assay. Okay. VDRL is the screening investigation in Sri Lanka. Can a patient be positive for VDRL and negative for, can a patient be positive for VDRL, however negative for TPPA? How? Yeah. Yeah. So for confirmation, you need the organism. So sometimes if the patient has been cured, right, the TPPA will be negative. However, the VDRL can be positive, right? So how do you treat syphilis? Yeah. So usually you give IV penicillin. What are the other drugs that can be used for syphilis treatment? Doxycycline can also be given for syphilis treatment. Any other drugs? Any other drugs? You can also give third generation cephalosporins, ceftriaxone. Okay. This is what is usually given.
Yes.
Thank you. So now what is the investigation for diagnosis? Obviously VDRL. So we go to the next one. Next one, even I didn't know. Those days. Study was conducted among a group of 1,000 males. Body weight was measured. The data was found to follow a normal distribution with a mean of 55, standard deviation of 10. Which of the following statement is correct? Okay. So standard deviation. What is standard normal distribution? In the bell-shaped curve, usually the mean, mode, and the median are all in the same position. Method standard deviation. Usually, method 50th centile. Again, 100th centile. Usually, right? Now the problem is this. Now make a frequency distribution. එතකොට අර සිම්පල් ලයින් ඩයග්‍රෑම් එකක විදිහට අපිට ගන්න බෑ. ඒ කියන්නේ ෆ්‍රීකවන්සි ඩිස්ට්‍රිබියුෂන් එකක් කියන්නේ වැඩිම තියනගේ තමයි උඩින්ම තියෙන්නේ. right? උඩින්ම තියෙන වැඩිම තියනගේ. mean of 55 ලු standard deviation of 10. ඔයාලා දන්නවා standard deviation means that how much of surface area is between how much area is between one standard deviation? 1 plus 65 again. How much is here? 60. Yeah. Third degree 99. Right? Third degree 99. Second standard deviation again plus or minus 95. And then plus or minus first standard deviation again actually 60. Okay. So now which of the following statement is correct? A person weighing 65 kilograms is in the center. Make it in the centiles. Standard error of mean would be about 2 kilograms. Median weight is 55. Right. So what is the equation for standard error of mean? Standard deviation divided by population के number के वर्गमूल, right? Check. What is the standard error of mean? What is meant by standard error of mean? Standard error of mean කියන්නේ sample එක දිගින් දිගටම if you sample it until infinity and draw a standard deviation for each of the samples that you get in each of the times till infinity, the pattern, the rough standard deviation of all those samples. Right? You guys look up. So this is the what do you call this standard error of mean. So make it 10 sample size එක ඒතර 10 වර්ගමූල කීයද? 10යි 1.10. මේක මේ කීයද මචං මේකගේ මෙයා ගන්න बिंदु 0.3 नहीं बस हुआ था right तर बिंदु 0.3 बेदीम 10 तर කීයද කියලා ගත්තොත් එහෙම right बिंदु 0.3 right right ඒ කියන්නේ මෙතන 1 කියලා අරගෙන එකෙන් අඩු කරනවා 1.5 නේ එතකොට එනවා 0.5 ඕක නේ උඹ කිව්වේ hey බෙදද්දී අපි අඩු කරනවනේ උඩට ගෙනල්ලා hey කොහොම හරි 0.3 එන්නේනේ so standard error of mean 2 kg කියන එක වැරදි median is 55 කියන එක වැරදි median mode තුනම එකනේ and then no one weighs less than 55 නේ alright so the median is 55 ඒක තමයි උත්තරේ okay ඒ කියන්නේ අනිත් ඒවා ගොඩක් දැනගෙන ඉන්න ඕනේ නැහැ median එක දැන් අනිත් උත්තර ටික හොයාගෙන නැති percentiles we can never identify because this is a frequency distribution right so the only answer is mean median mode තුනම එකට තියෙන හින්දා standard deviation එකක් normal distribution එක එතකොට ඉන්න එකම එක අගේ කියන එක තමයි නැත්තම් මේව හොයන්න බෑ කෙස් පැලන තර්ක මේව ඔය ඉන්න පුළුවන් paper එක ඉවරනකම් but you can't find the real reason okay okay so we go to the next one mama make even at that time I didn't know how make the okay so the next one 16-year-old boy presented with flitting type arthritis and chorea what is the diagnosis sore throat 3 weeks ago mid-diastolic murmur in the mitral area what is the diagnosis acute so what is the underlying immunological phenomena behind acute rheumatic fever group what group B what sort of immune hypersensitive reaction is this type 2 type 3 what
type
2
type 2
why that day I told
antibody skeleton
glomerulonephritis
oh
right so arthritis is due to circulating immune complexes true or false false antibodies synovial joint biopsy reveals eosinophilic inflammation true or false false neutrophilic inflammation disease is due to hypersensitivity to streptococcal antigen we'll keep it for a moment and then we'll go staphylococcal antigen true or false false type 2 hypersensitivity reason is the reason for carditis true or false true why do they get carditis and arthritis because these agents are present in the valve surface and also in the synovial lining okay this is why they get arthritis and carditis that is why they because the inflammation due to type 2 hypersensitive reaction takes place at these areas okay okay so we go to this one 45-year-old woman with
Korea is hidden hand Korea
yeah chorea is because of what basal ganglia වල තේ receptors තියෙනවා ඒ වලට antibodies join වෙලා දැනත් inflammation එකක් එනවා හරිද
okay
so 45-year-old woman with atrial fibrillation due to non-valvular heart disease is being considered for direct oral anticoagulation therapy instead of warfarin what of the following statement is correct regarding DOACs comparatively lower bleeding risk due to overdose true or false true
false no true
right reduced incidence of thromboembolism true or false false warfarin is still superior reduced risk of intracerebral bleeding true or false false the main problem with these drugs is GI bleeding and intracranial bleeding right used for rate control true or false false maintain heart in sinus rhythm true or false false what is the main advantage of using DOACs
monitoring is
note.
like less.
No need
Yeah,
of INR
no
monitor.
need.
Can you use DOAX for valvular AF? Now this patient is having non-valvular AF, no? Can you use DOAX for valvular AF?
Can?
No.
No?
Can you use
What?
DOAX for APLS patients? No. For all those conditions, you have to use warfarin. Oh, yeah. Can you use DOAX in pregnancy?
No, right? There's like
No.
certain time.
There is less evidence. Okay. So this is also very commonly asked. Last 2017 MCQ also was there. Out of warfarin and DOAX, what is the drug that changes its concentration depending on dietary changes?
Warfarin?
What changes due to alcohol consumption? Both are warfarin. Usually, DOAX do not change with or interact with the food you eat. Okay, so remember that. You see. In a patient with non-valvular AF, what is the score that you use for yes, chat
Is
box.
that good? Oh. What about that valvular one? What do we use?
For valvular one, what is the score that you use?
I thought jetpacks.
No, no score is there. For all patients with valvular AF, you must give what? Anticoagulation. With what? DOAX, no?
Mm.
No, with warfarin. You need to give for all patients with valvular AF, DOAX cannot be used. You have to give warfarin. Okay. මේවා දැනගන්න
Yes.
මෙන්න මේක I also got it wrong. It's not inferior or superior to warfarin in efficacy. So DOAX and මේක දෙන්නටම same efficacy, right? Same efficacy. And reduce risk of intracerebral bleeding කියන එක හරි කියලා දීලා තියෙනවා. Less bleeding than warfarin. So I think the answer to this is actually this. Reduced risk of cerebral hemorrhage කියන එක. Or less bleeding කියලා තියෙනවා. ඒ කියන්නේ chance එක අඩුයි කියලා. No monitoring කිව්වොත් අනිවාර්යෙන් ඒක තමයි කරන්නේ. No difference in ඒක තමයි මේ Watchman කියන ටෙස්ට් එකෙන් තමයි හොයාගෙන තියෙන warfarin versus DOAX වල efficacy එක. ඒකෙන් හොයාගෙන තියෙනවා there is no difference in bleeding, no difference in thromboembolism, no difference in mortality, right? No difference in device related thrombosis. Efficacy is usually similar, but yeah, so usually efficacy is similar. Overdose එක තමයි ප්‍රශ්නේ තියෙන්නේ. DOAX versus warfarin overdose කියනවා. DOAX versus මේකත් තියෙනවනේ. ඕවර්ඩෝස් එක කතාව පොඩ්ඩක් අතහැරියොත් reduced risk of intracerebral bleeding කියන එක හරිනේ. මේක තමයි දන්නේ නැත්තේ. less bleeding කියලා තියෙනවනේ. හැබැයි no difference in all bleeding කියලා මෙතන තියෙනවා. මෙතන තියෙනවා less bleeding. මේ වන්දන. මෙතනක් තියෙනවා fewer fatal bleeding events කියලා. අනේ වන්දන. ඒක මම I'll check properly and let you guys know. Okay. I'll ask for my boss. Priyanka sirගෙන් අහන්නම. හරි නේද? I think we left one MCQ. කොහේ හරි තිබ්බනේ අපේ MCQ එක අතෑරියේ. එකක් අතෑරියේ කොහේ හරි.
Did we?
I feel like so. We left out. ඒක තමයි මට සාමාන්‍ය ඔය වගේ මගේ ඔළුවේ තියෙනවා. කොහේ හරි කොනක තියලා මට කියලා නෙමෙයි. පීට් එකේ අපි අතරින් පීට් එකනේ මට මේකේ ඔයාලට හොයලා දෙන්නම් කියලා ගත්තොත් මම පොරොන්දු වුණානේ මම හොයලා දෙන්නම් කියලා පොරොන්දුනේ මම හිතන්නේ මෙන්න මේක moderate dose of statin කියන එක use කරන්න පුළුවන් කියන එක. I'll find it out and let you guys know. I'll do a separate class for you, especially for all patients, all people doing medicine, right?
Okay.
Special class on these things, right? Special class on number one, therapeutics. Therapeutics means the common pathological mechanism. The common pathological mechanism of MAHA is these patients get small blood vessel, small clots, right, in the arterial tree, in the blood body, right? So what happens is that because the clots are being formed, all the clotting factors reduce, right? And also the platelets are used up, and so platelets also reduce. And what happens to the RBC when they go through these clots? They get cut into small pieces, right? Understood? These clots are like razor blades, so they get cut into small pieces. And these piecemeal RBCs are also called as what? Schistocytes. Right? And then also when RBCs are destroyed, what will happen to the hemoglobin level? Reduced. And also what will they have? They will have hemolytic anemia. Why? Why will they have hemolytic anemia? Because RBCs are cut into small pieces inside the blood vessels. So it's like intravascular hemolysis. So the common features of this is clotting factors reduced. So what will happen to the PTI in a MAHA patient? Increased. What will happen to APTT? Increased. What will happen to the platelet count? Decreased.
Decrease,
Why?
no?
Clots, no? Okay. What will happen to the hemoglobin?
Decrease.
Decreased. What will happen to the blood picture? Schistocytes. And what will happen to the liver functions and renal functions? Not renal functions, we'll say bilirubin levels. Yes. What type of bilirubin is increased? Indirect bilirubin levels is increased. Okay. And then because there is hemolysis and there is clotting factor consumption and platelet count reduction. These will actually ultimately cause microvascular microthrombi. We call these small blood clots microthrombi, and this will cause microangiopathy. Right? Again, small blood vessels destroy organs. Because of that, these patients will ultimately have end organ failure. Commonest organ to fail is renal. Right? So they will get renal failure. They will need dialysis. They will have AKI, and they can also have liver failure. And then because of severe anemia, they can also have heart failure. And then because their clotting factors are now reducing, and because of their platelets are reducing, they can also get what? Severe bleeding. What are the life-threatening bleeding that a patient can get?
Hemorrhagic?
No.
I see.
Severe bleeding is considered mostly in two areas of the body. One is cranial cavity and the other one is GI. So if you get severe intracranial hemorrhage or intracranial space occupying lesion or severe GI bleeding, that is called severe bleeding. So these patients can get severe bleeding. So bleeding, and because of clotting, they can get renal failure and these things also. And sometimes, because these RBCs are destroyed, this can precipitate blood clots, right? So they can present with clot formation also. So they can get clots everywhere. So they have increased chance of DVT, right? And what comes with DVT? Pulmonary embolism, right? So this picture is called MAHA, right? Microangiopathic hemolytic anemia. And the causes for MAHA are many, right? Causes for MAHA. What are the causes for MAHA that you know? Hemolytic uremic syndrome in pediatric patients with dysentery. Eh? What else? Sepsis will lead to DIC. Sepsis patients already, if they get activation of clotting factors due to the severe infection and cytokine storm, that will cause DIC. Any other reasons for MAHA? ITP? No. TTP, right? TTP, there is a defect of ADAM-ST3 protein, ADAM-ST13. Because of that, von Willebrand factor and platelets cause clots, and these cause hemolysis. Okay, and then what else? What else? Causes of MAHA. HELP syndrome, have you guys heard? Where do you get HELP syndrome? Yeah, in preeclamptic toxemia. Right? In preeclampsia, these patients can get HELP syndrome. So the patient will be pregnant. Right? So remember, what else? What else? What are the other causes of MAHA? What drugs usually cause MAHA? Calcineurin inhibitors කියලා එකක් අහලා තියෙනවද ඔයාලා? Tacrolimus කියලා drug එකක් අහලා තියෙනවද?
Tacrolimus cyclosporin?
In patients with renal failure and have undergone renal transplantation, they get tacrolimus. So usually that can also cause MAHA sometimes, right?
Mm-hmm.
So we'll see. These are the causes of MAHA. මේවා ටික හරියටම දැනගන්න, because they can ask in the exam, because they have now asked the same topic twice in a row. So no excuse that they won't ask this in the repeat here, right? Sometimes they might ask. So these are the causes: malignant hypertension, disseminated intravascular coagulation, hemolytic uremic syndrome, TTP, SLE, cyclosporin, gemcitabine, mitomycin, and then calcineurin inhibitors, right? These are drugs which can cause MAHA, right? Okay, so these things can cause MAHA. And in MAHA, how do you treat MAHA? Anything with, I mean, knowing only the pathophysiology is not enough. You need to know about treatment of MAHA as well. How do you treat MAHA? you need to treat MAHA with supportive care. Okay? So there is one aspect is supportive care and the other aspect is definitive care. So in definitive care, you need to treat the cause for MAHA. So if the cause is sepsis, treat sepsis. Okay? And if the cause is drugs, you need to remove the drugs like cyclosporin and tacrolimus, everolimus. And if the patient is having preeclampsia, what do you do? Huh? Can you treat high blood pressure and remove preeclampsia? Gymnox. What do? You remove the placenta, you deliver the baby. That is the only treatment for preeclampsia. A balaganna, Gymnox. And then what else do you do? If it is dysentery, you treat with IV antibiotics. Right? So you need to treat the cause, and then apart from that, you need to give supportive care. So you need to give renal failure. You can do hemodialysis, right? And you can correct electrolytes and acidosis, okay? And then you can also give for severe reduced hemoglobin levels, you can give red cell transfusions. And then for severe platelet reductions, you can give platelet transfusions, right? And then for these protein factor reductions and severely increased INR levels, you can give fresh frozen plasma transfusions. Okay, and then and then if the patient is having thrombotic tendency, in the sense that patient is having increased risk of forming blood clots, you can give the patient IV anticoagulation with what? With IV or IV heparin, right? Or if the patient can tolerate, we can give enoxaparin. This is treatment of MAHA. This is diagnosis of MAHA. And this is the causes for MAHA. මේ ටික මතක තියාගන්න හරිද? තේරුණාද? Understood?
Yeah. Yes.
So, what is Evans syndrome? Remember Evans syndrome also, because they have given, or they might ask again. In Evans syndrome, usually you get ITP with hemolytic anemia, right? So there will be reduced platelets, but usually the clotting levels will not be abnormal. They will be normal. Okay. Evans, I don't know actually the pathophysiology. I'll read and I'll let you guys know about Evans also. Okay. So, ඒ ටික නිකන් දැනගෙන යන්න. නිකන් just important නේ. කීපවතාව පහපු පැතිනේ. There is high risk of asking again. Okay, so with that we finish 2018. I'll start discussing about pediatric.